Belfast for the Health and Social Care Board, and I'm the representative for the Health and Social Care Board on the Belfast Community Planning Partnership. And the planning partnership asked me to lead on an area that they felt was a very important priority for the new Belfast agenda, which is the community plan, which was really to support people to really support vulnerable people with help over the winter period. This is really building on work that obviously NEA had been working on for some years with the support of the Public Health Agency, but also that I had been leading on as chair of the Healthy Aging Partnership in Belfast. Given the new kind of methodology of outcomes-based accountability, we want to start with what it is we're trying to achieve and what are our aims. And one of the key areas really was the excess mortality that we were seeing in Belfast. It does go up and down, and over the last 30 years, it's been quite volatile. It's not really quite obvious what causes it to be volatile. Sometimes perhaps it's the prevalence of flu, and sometimes it might be colder winters and so on. But we know from evidence that cold homes and cold weather are both potential killers of people with long-term conditions. So with the significant rise really in the between 16, 17, 17, 18, last year, the partnership really wanted to focus on this and see what we could do about it. So who is at risk? Well, NICE in their guidelines really identify quite a number of people who are at risk, not all of them older people, some of them with long-term conditions, and indeed some who are younger, and women who are pregnant. And while deprivation and areas of low income is an important factor, it's by no means the only factor. So we would tend to focus our actions on areas of inequality, of multiple deprivation, but we just needed to be careful that we were taking the whole range of factors into account. When we look at age is really the main factor, and we can see that, you know, as you reach older age groups, 75 plus, in particular 85 plus, the risk of death is significantly raised. So looking at the guidelines that NICE give us, I've summarized them here: partnership approach and a stratified plan, so for escalation with lower temperatures, a year-round preventative program, which is something that we're really focused on now, particularly the relationship actually between fuel poverty, climate change, and employment around retrofitting homes and energy efficiency, which we've managed to really convince the community planning partnership should be the business of everyone, every partner, and all communities. And they've really taken that to heart, and maybe we can come back to that in some of the discussions, but we're now influencing the new energy strategy, and hopefully when it comes along, the fuel poverty strategy, as well as the resilience plan for climate change and emergencies in Belfast. So we've taken it to another level, if you like. But our particular focus in this particular project last year was on identifying those at risk. So we used our information on demography, the data from all of our various partners, not just health, but other partners as well, to try and identify those who are most at risk. And sharing data is definitely one of the areas that community planning partnerships are particularly interested in testing. And I think it's the lifeblood really of community planning partnerships. The the core of this really was to designate a single point of contact, and in order to coordinate the work not only of our partners, but also of local communities and their response to people who are vulnerable. NICE also recommends discharge to a warm home, and that's something that we've been working with the Belfast Trust on, and also then training needs analysis programs for frontline staff. Now that's something that we're looking at. How we tackled that last year was really looking at making every contact count. So it was really making sure that all frontline staff across health, and this year hopefully housing, and libraries and sport and so on, were all aware of the dangers of the cold weather and what to look out for to become our eyes and ears. We really had an approach then at two scales. One was citywide coordination, so that kind of communication of health protection messages, work among the most vulnerable groups like homelessness and older people. An attempt to have an escalation plan as temperatures fall. So working with the emergency planning team in Belfast to look at what could be done to ramp up action as the winter progressed, and the coordination across the city of a single point of referral. And then within the localities of greatest vulnerability, and we started off with 2 pilots, a more intensive approach to tapping into all social assets. And really, this is not so much a needs-based approach as an asset-based approach, really, that I'll speak about a little more in a minute. And we, Hugh and I, particularly with others from NEA and the Council and the Public Health Agency, went along to the various community and voluntary groups in the areas to try and make sure that they were fully aware of the message and that they were really forming local warm and well groups to try and spread the message and coordinate action. So the citywide coordination, some of this, the different elements were already being done, but they weren't being coordinated. So identification for advice and referral, particularly through NEA, assessment and arrangement of support. And there were various groups really arranging support. It wasn't particularly coordinated. So the service response really sometimes was a bit disjointed. And the awareness of the work that NEA were doing and NEA's awareness of some of the community groups that could respond, we had to connect those together. And we have started some of the evaluation. Has been a bit truncated by COVID because you can't really follow up with people so easily and get their feedback as to whether we did make a difference or not, but we're working on that at the minute. So we did go around the various community forums. We had an overall workshop where we looked at capacity coordination and the kind of conversations you would need to have with people who are not particularly health literate in many cases, really, and don't understand what they need to do to protect themselves from the cold and what is available in terms of advice and help. The coordination of, as I've said, and NEA have worked actually quite closely with the Belfast Trust Connected Community Care Service and the Council's Affordable Warmth team to make sure that there's a complete coverage there. And then advice to public-facing staff and volunteers to make sure that we were getting the kinds of referrals from the vulnerable areas that we were looking for. So we did identify 2 pilot areas. If you can see on the screen, the blue areas are those which were we had identified a particular vulnerability, but the dark blue areas, one more to the top of the map in the Shankill area, North Belfast, and the 2 sort of blobs we counted as one area really in the Andersonstown area of West Belfast. But you can see that actually the most southerly area of blue is actually in the Malone area, which is quite affluent, and over to the right-hand side or the east, you've got Gilnahirk and Stormont as areas where you'd think, well, you know, they're not deprived. What do you mean? Is it not related to fuel poverty? But we did say that age was a particular factor. So that's why they're popping up there. And in fact, one of the areas with the greatest excess deaths in 1718 was in one of the most affluent areas in Stormont. So I think, you know, being data driven has really helped us with some counterintuitive approaches. So we picked those two areas just to pilot it, and we will be expanding this year into all of the blue areas. So what we did in those two areas really was to map the assets. So who could help us with this? Who could identify individuals? Who could refer individuals? Who could help with the response? And how could we mobilize really all of the assets in a particular community, but in a coordinated way? And Hugh will talk about that in a bit more detail. But we did contact funeral directors, taxi firms, lunch clubs, the police and fire service, and so on, to help us to try and identify as many people as we could who would fall into the risk categories. So that really sets that out. We did a lot of sort of foot stomping around the areas to make sure that people were aware of what we were doing, give briefings to community staff and so on. We produced a leaflet which gave all the information, and then that people were able to just hand that out. You didn't have to have a full conversation with people if they didn't want it, but you could hand that to the leaflet to them, and it had the single number on it, so that got them through to Hugh and the team in NEA, and all kicked off from there. In terms of evaluation then, before I hand over to Hugh, the NEA were funded to some additional funding really to collect data on referrals and response times, and we're analysing that at the minute. But as I say, administering the outcome wheel, which we devised really to measure the impact, has been a bit difficult at the minute, given the difficulty in going back to people to find out what the impact was. So we'll be looking at that over the next few months to see what we can do there. But we did measure not only people's response, but also their attitude, and whether in fact their house was warmer at the end of the day. So I'll hand over to Hugh at that point.
Is that?
Yeah.
Okay. Mm-hmm. Hello, I hope everybody can hear me. As Ian says, what I hope to do is, and Ian's already talked a little bit about, I suppose, NEA's role and history in trying to move forward, particularly in terms of implementing the NICE guidelines. So I'm going to give you a little pot of history of some of the projects NEA have run, overview of Warm and Well, and as Ian says, I'm going to talk to the initial findings which have been pulled together by Laura Gillespie, arising out of that sort of first tranche of cases that were examined. So I suppose to give you a bit of background on our journey into Warm and Well, the Northern Exposure Programme has been running for a number of years now. And on the left, I don't know if you can, well, if you can see my cursor moving about, and I've been assured I can from our technical bod, Nicola. He's waving frantically. But I suppose Northern Exposure Programme was set up and then rolled on through various pieces of work have been done over the years. For example, projects that were done up in the White Rock areas and around better insulation, Warmth at Home project that was set up with the respiratory teams within the hospitals. And I suppose we've always had those roots into NEA, and you can see them down the left-hand side there, whether it was, and more recently, connected community care, and in particular, self-referrals. And our role, I suppose, up until the introduction of Warm and Well would have been primarily to go out, complete a home assessment if it was required, but with, I suppose, the focus more on the thermal comfort of the house, and then what measures could actually be put in place to alleviate those circumstances for the individual. But increasingly, as referrals started to come through, over on the right-hand side, that red box, increasingly those unidentified needs were coming to the fore. So initially, you may have received a referral about an individual with no heating system, but when you went out and looked behind the issue of no heating, then there was a plethora usually of other issues which required the input of other organizations, other services. And the initial stages for us was, right, okay, but how did we establish, if you come across those links with the likes of Age NI, Advice NI, particularly if it was financial matters, like the British Red Cross, in terms of befriending schemes. So it was, we were certainly delighted as an organization, and in terms of delivering projects, that when the conversation was begun in January of last year, long before it was ever called the Warm and Well project, but that actually the NICE guidelines were actually being discussed, and that there actually was a call from the assembled groups and organizations to actually now start to move towards addressing this issue. So for us, always in our early sort of thinking, from Northern Exposure to Belfast Warm and Well, but we had always advocated was that we already had an existing lines of communication into NEA through a referral source. But very much, as Ian has said, it was about how did you mobilize, or how could we mobilize the local community and the local community assets. And so obviously the challenge then was, how do you bring the left, the left and the right to meet in the middle? Whereupon an assessment could be undertaken using an outcomes wheel. And as Ian has already said, it's been difficult, obviously, with the onset of COVID and throughout COVID, to go back and actually ascertain, well, what was the real value of the intervention, right? But I'm going to talk a bit more to that when we talk about some of the information from the gathered through the baseline assessments, okay? So, as I said, in terms of Warm and Well, phase 1, the initial findings, in terms of, and really we had to reach a cutoff point. So actually the numbers that were actually looked at in terms of this initial, or gathering initial findings was 91. But in the period where, as we went into April, actually the numbers were actually up at 125. So, but the findings are based on 91 referrals. And as we've gone through COVID, it's approximately remained the same, where we've made 90 odd different types of interventions throughout COVID. So in terms of referrals, just an overview of the referrals, I said we had 91. In terms of sort of follow-up, with 6, where you are phoning, and what we've built into our data capture was that we would go back to them a minimum of 3 times. So whether that was message, whether it was phone call, whether that was following up with a phone call, 6 people chose not to. We undertook 76 home assessments. Advice was given to 3 people over the phone, and there were 4 inappropriate referrals, where that could have been somebody who'd got wind of, in one case, of Warm and Well, had installed a new heating system, and now was wondering whether we would pay for it. So that went into the inappropriate referral box for obvious reasons. Interventions, and I'm going to give you some detail on the type of interventions a little later on, but over 140 different types of interventions were made. Sometimes there was multiple interventions, depending on the needs of the household, particularly where there were perhaps single parents, low-income households with children under the age of 5, which required different interventions, but all being delivered at the same time. In terms of type of response, because obviously what we tried to do, considering the numbers, was we needed to triage and prioritize. But of the total number of responses, 63 were deemed to be emergency. And so even coming into and during COVID, that emergency response, whether it was evening, weekend, bank holiday, the program was still able to deliver those interventions because not fortuitously, but it was advantageous that the work that had been done in the lead up to January paid a dividend in a different way as we entered into COVID, because with agreement of the working group, we just continued to be able to deliver those interventions for those people, particularly people that had received shielding letters. So in terms of source of referral, as Ian had said earlier, it was really about targeting local community and voluntary groups, those community assets, the health professionals. And you'll see there, but interestingly, and again, I think it's testament to the communications campaign that was undertaken by the council in terms of going out and targeting those areas, putting the resource behind it, publicising exactly what Warm and Well was, even to the point where people that were self-referring had maybe picked up a leaflet in a library, which happened more than once. So those local networks, those local community settings where people would take a bit of respite during the day, that information was there. So it was. In terms of where the referrals were coming from, as Ian said earlier, it was very much about taking a targeted approach, and the two areas that were identified were in North and West Belfast, and within that then there was 2 to 3 different wards, right? So data was collected. 15% of all the referrals came within those super output areas, as they are known, which represents 4% of the Belfast population. But actually what we seen develop as the project ran on and more people became aware of it, that actually the spread now went across the whole of Belfast. And that is something later on in terms of our next steps that I will talk to, and Ian's referred to there in terms of expanding the reach and capacity of the project. West Belfast had the highest number of referrals, with 34% of all referrals coming from West Belfast. Right. Over half the referrals came from the top 20 most deprived areas in Northern Ireland. The interesting thing again, which if you think back to previous slide, where the highest number of excess winter deaths came from one of the most affluent areas in Belfast, 10 referrals came from the top 20% least deprived areas, which again points to it does not discriminate, particularly a lot of older people who've invested in the bricks and mortar. That has been the panacea, get the mortgage paid off with little thought to what comes after that. And increasingly, that has become an issue. You're getting into areas, and yes, if you were being very judgmental, you'd say, why am I here? But when you go in and you get behind the door, you see the reality. That tends to be more people than we would imagine actually would need this type of service. We talked, part of our data capture was to complete a baseline. And what we looked at was under 4 domains: health, benefits, warm homes, self-advocacy, and resilience. And part of that again was about, okay, if you think about, yes, people's health, their willingness, ability to advocate for themselves, levels of self-interest, and what or how would they do to keep their home warm. So we had used a range of 1 to 5. So for example, if I said in terms of keeping your home warm, people who scored a 1, they would be answering, I don't think about heating my home. Through to a 5, I feel warm in my home, I ensure my home is energy efficient as possible. So that was the scale that we used. So our trigger was basically anybody scoring a 1, 2, 3, falling within that range. Then there was a high probability that there was some support required over and above what was being requested, perhaps in terms of immediate intervention and longer term measures provided by some of the schemes delivering those measures. But if you take a look, if we take a look at line 1, 2, or sorry, score 1 and 2, and you see the numbers there that are showing a 2, or scoring a 2, particularly in benefits, and increasingly, we would anticipate, and part of the planning for this winter is around, we had an article in the news last night about the increase in unemployment figures. That is likely to become even more of an issue and place other people. For example, I took a referral from a food bank yesterday. Guy's just lost his job. roofer. His previous employer took the tools back. He's just about made the mortgage payment. He signs up for universal credit, and it's going to take a few weeks even to verify his identity. So we would expect the demand to increase the further we go through the autumn and into the winter, right? And the idea behind the baseline was where you had people scoring 1, 2, 3, and obviously you were asking about the 4s and the 5s, right? But it was okay. So who exists in those areas, and what is the type of referral? So is it to an organization that will perhaps befriend someone, particularly as we went into COVID, any concerns we might have had about somebody that was living on their own, that they weren't lost to those local services in terms of, listen, will you check in on such and such? They are living on their own in such and such a street, and they've got no immediate family support. So it was more than just about looking at people in immediate need or longer term need, but it was about how could we possibly hook those into the other services that were identified by completing that assessment. And if we take a look at the top, or sorry, the most vulnerable sort of 10%, you'll see the sort of information that was coming out around, excuse me, those clients. So in terms of the usual sources, community voluntary, connected community care, other, could have been friends, could have been family. But 8 out of those 9 people had no live-in support. So they were completely on their own, right? 8 out of 9 were determined to be living in fuel poverty, well below average sort of income levels, right? Interestingly, 7 out of those 9 had no flu jab and expressed no real inclination to go and get it. Now, bearing in mind, this was at the outset, pre-COVID. That's something that we want to support PHA in the future in doing, is getting out those key messages, particularly around the flu vaccination. From the 21 interventions identified for those 9 people, 13 were deemed to be urgent and 8 non-urgent. And in terms of age, 7 out of the 9 were under the age of 65. However, and also 7 out of those 9 suffered a serious chronic condition. Just in terms of the type of interventions, right? And this, I suppose, has been one of the real benefits of Warm and Well, that the project team, as it would be called, agreed that NEA were keen to make use of a fine that had been, or monies that had been seen from the utility regulator raised by way of a fine. And the project team, Community Planning Partnership, City Council, match funded to allow us to create a pot that could be used to deliver immediate interventions. Because historically, one of the issues about delivering any project is you can take the information at referral source, you can complete the assessment, but actually in terms of meeting the immediate need, what practical measures were available? And until the introduction of Warm and Well, we were able to do very little. You were constantly tapping into very small pots of money. This allowed us to create a fund where, following assessment, we could provide the level of intervention that was needed, whether urgent or non-urgent. And if you see the type of, and including the likes of, it goes back to, you know, the data capture that we were using, you'll see some of the agencies, whether we were going to food banks, and that increased more as we were going through or coming through COVID, but the likes of emergency fuel, winter warmth packs, straightforward measure as simple as going out, being able to go out and buy oil-fired radiators and put them in somebody's house 20 minutes or half an hour after you've left it. And then in terms of home improvements, and that's where you're bringing in other agencies. That could have been draft exclusion measures such as that provided by other organizations. And then non-urgent, you have the usual, I suppose, advice and information, discussing energy efficiency, right? Again, access and financial support, and the, again, home improvement. Right? Some of the key learning points that come out of it, and again, serve to inform were, or some of the issues that we're looking at now. The data certainly indicates that the target approach that was taken by the project team has clearly resulted in referrals coming from those areas. But as I said earlier, once awareness of the project increased, then referrals were coming in from across Belfast and from all 4 areas. Certainly, the resource has proved that there is a need for the urgent and non-urgent referrals in terms of the type of intervention. Because otherwise, and particularly as we came through COVID, that really was shown to benefit those people that were most in need. So, and again, as we go forward, that resource will remain in place. Again, one of the things that we talked to earlier was that over half of those that reported on the flu vaccination had not actually been vaccinated. And again, in terms of key messaging for us as a project team and delivering the project, we will certainly be promoting public health agency messaging around vaccination. Again, the numbers of interventions focused on supporting vulnerable people with addressing energy inefficiency and fuel poverty, right? They will always sort of be, that will be the predominant reason for making the contact. However, in behind that, as we've said before, in terms of capturing the data, wanting to utilize community assets, that is often just the tip of the iceberg. And again, as we go forward, we're looking at, right, okay, well, how do we improve those processes, that infrastructure, make better use of infrastructure as we come into winter. Also picked up that, as I suppose Nick really just touched on there, that the needs identified go beyond addressing fuel poverty. And it really does provide us with an opportunity to now at this stage, really boil down and identify those organisations within the existing structures that are available within the Belfast Council area, and how in turn do we make that more focused and more targeted. Certainly there are opportunities to engage with other sectors, certainly as we've gone through COVID and before, particularly in housing and homelessness. We had a few referrals, and that is something particularly when we look at the opportunity to avail of those services that are funded by supporting people to deliver floating support. We'd clearly like to see that strengthened, and that's certainly something we'll be following up on again. The opportunities are there, and and certainly we're forming to create support tailored to local responses. That was very hard, I suppose, to sort of keep track of then as we went into COVID and pre-COVID, where you had local community groups, organizations, partnerships, and they were gearing up for what was coming, right? So that again is something very much about revisiting and making sure that actually in terms of an overall available resource, we're not diluting that resource by sending it off one direction. When you have that single point of contact, you have that service. And I think that's certainly one of our learning points is how do we get better at that, because the pot is always going to be finite. Why reduce its possible impact by diluting it? And then in diluting it, are we actually losing the control of that resource? So that is very much something that we want to try and nail down before we come into the winter, is how we use those structures to focus the available resource much smarter. It certainly has enhanced the use of asset-based approaches, because anyone who'll know, or anyone who's ever delivered a project or managed a project, you will know that the success of any project relies on relationships you have with other organizations, because everybody will know somebody in a certain organization that will go, I know I'll go and talk to Joe over there because he does that, and I know if I go to him, that's going to be done. And that has to be, I suppose, our working sort of protocol now, even more so now, but especially as we come into the winter, is that everybody is very clear on what others are doing within a given area, and that we're not duplicating and in some cases replicating what is happening, and that we're making best use of both the service and, as I say, the resource. Okay. So for us, in just conclusion, where we are now, very much around key messaging in terms of public health agency. You know, increasingly, part of our role anyway is to raise awareness, but now we find we'll be raising awareness around the Stop COVID app and the importance of test, trace, and protect, and particularly flu vaccinations. We talked, or Ian certainly talked about when Matt was up in terms of building capacity and extend reach, where initially the project was set up to look at specific wards within 2 targeted areas. As a result of, I suppose, the referral sources, where they were coming from across the city, the impact of COVID, the unknown impact of COVID, yet to be realized as we come into winter, that there was a need to build further capacity within the project and extend the reach of the project across other areas of Belfast. And that in turn certainly much leads us then to start to look at, as Ian had mentioned through his slides, part of the awareness raising campaign involved Ian, Andrew Steenson from the council, myself, others going out, talking to community groups within the targeted areas. And there was certainly real benefit in that. And I suppose with the onset of COVID, we need to revisit that. But certainly as we go forward, we want to target communications and training at those organizations that would have been identified or have been identified within the existing council structures. So you've got the area management team, you've got the area partnerships, and then within that, you've got designated organizations. And so how we manage that message, manage the referral streams, manage the process, certainly there would be the absolute benefit for project delivery in utilizing those existing structures. Whenever we went into COVID, and it's completely understandable, areas were mobilizing, individuals were mobilizing, you had various, helplines being established, and that was dealing with the immediate response. But it comes back to the thing, the more, I suppose, avenues there are, sometimes the message can perhaps get a bit lost. So it is very much about, okay, how do we make sure that the people who are going to be giving the advice, the people who are going to have been identified as delivering the service on the ground, have got ease of access, are using straightforward procedures, we're not duplicating each other's work, right? And that we make better use, especially for ourselves, of the available technology. And I think, as Ian has said, data sharing is key. So that when we do something once, we're doing it once, and the relevant parties that need to be involved and have the information so that they can do the part of the package that needs to be delivered, that they can do it, and there are no holdups in the process. And to do that, as I said, that requires sharing and requires integration. And that work's already underway in terms of developing easier data capture processes, making better use of technology, utilizing our IT department to help us make it as straightforward as possible. And those are just some of the things that we are working on at the moment. As we come into autumn and into winter. So that's all I have, bar to say thank you. And if I appear on your screen as I look at mine, like, I don't know, what do you call that movie? Whatever happened to Baby Jane? And she just sat up in the dark room all day. That's what I look like. But anyway, all right. But thank you for listening to myself and Ian. I need now to talk to my colleague because I don't know where it goes to. What happens now?
You stop sharing.
Are you taking questions, Hugh, from the attendees?
Okay, so, okay. Do I just,
Well, if anybody would like to ask a question, you can turn your microphones off and turn your cameras on, and we'll be able to hear and see you.
What I do?
Yeah. If you
Stop share. Okay.
Yeah. Okay. So loads of people.
Where's my volume? Oh no, what do I do there? That's a picture.
Any questions?
If I could ask a question, you spoke there about duplication and avoiding duplication, and I just wonder, you know, I suppose the experience of COVID was that there were lots of people in, you know, maybe particularly in the community sector and very local, doing things, and there was a significant amount of duplication. And I suppose I fear that people will, if we are to enter a second wave, that people will think, well, you know, I offered to help last time and nobody took me up on it, and I wonder, will we suffer a loss of goodwill from some of the sectors that responded the last time, and whether you have any thoughts on how that might be avoided?
Who's that?
Yeah, I think that's. I've certainly got plenty of that feedback, you know, from local community groups and from councillors and so on. I think one of the difficulties within the health service was that we couldn't share the data on shielded patients, and you know, I think, you know, because they were regarded really as medical records, and that was difficult. Although we were able to get over that to some extent by our social prescribing scheme, the connected community care that we referred to as we went along, because they take referrals directly from GPs, that at least some of the where the GP knew that there was a problem, they were able to send them through, and then the connected community care service could link with you. But that wasn't exactly what we were planning, which was a single point of referral. And I do think that a lot of lessons have to be learned between the Department for Communities, Advice NI, the council, the trust, the GPs, and the local helplines. I suppose it was a bit of string and glue, really, to try and get those organised together. I know, Hugh, that you're talking to Advice NI about at least being aware of the NEA service, and that's one way that we can sort of tap into that.
Yes, but we've had some discussions with Advice NI, I suppose for ourselves as well, and helping to improve our understanding quite early on into COVID, how various resources were being used or accessed and used. And for us, it was important to get clarification too. And certainly we shared, obviously, the information around our service and a method of assessing someone perhaps that might be in need of an intervention as a result of living in fuel poverty, perhaps were shielding, had other complex health issues. And what we were talking to there, or I suppose in our next stages or planning, or certainly what we're looking at now, is that actually those structures existed. And to be fair to everybody, right? Nobody ever saw the scale of what was coming, right? And so the response, yes, well-intentioned, it was immediate in most places. And like most goodwill, at some point you step back. And yes, everybody can say hindsight's a wonderful thing, but hindsight, in my opinion, is now. So we now know what it is we need to fix. Will continue to be hindsight if in 2 months' time we go into winter, nothing's been done about it. However, we're working on that now, and that is about looking at those existing council structures within Belfast that are coming out from the centre, and then where do we as a project fit with those, and then those organisations in turn, if it gets to that again, how will they mobilise the local resource, right? But do it under one banner as opposed to, for example, I was talking to somebody yesterday, or manager in a food bank yesterday, and what they were saying was that at various times it was almost like there were pop-up food banks. But I suppose the question was, you had an organization that had coverage and presence across all 4 areas of Belfast. And I suppose in my head, for what it's worth, common sense would say, okay, you look at what you got, what has been there for a while, and then you make them responsible for coordinating the response in those areas, rather than, for example, you might have had 2, 3, 4, whatever it was, different organizations offering food, right? And that needs to be the response that I feel anyway, is that we take across the board. So whether it's food, whether it's fuel poverty, whether it is somebody that's living on their own with absolutely no means of support to access. So for us to go forward, it will be about identifying, so who is the person that might be able to provide the befriending service in that area? Who is the person that, if it's needed, that they need a food parcel? Who's the one stop that I'm going to? Not if you phone such and such, or if you phone such and such. And as I say, hindsight's great, but hindsight's now. And those are the things, certainly in terms of project delivery, that we are looking at, because that was the learning that we took out of both the initial pilot and as we came through COVID, that we needed to be smarter as well.
Okay, thank you.
You mentioned that the winter months are coming and the service. Do you envisage a big uptake as the days get colder, and how are you going to cope with that?
Well, in no way was that a planted question, folks, from my colleague. But I see where you're coming from, Lucy. And you will know, having delivered this project before myself, that all through the summer months, with or without COVID or anything else having a bearing, you would be very lucky to get more than maybe 10 phone calls a week. And the first crack there is in the clouds, we are inundated with people talking about, I have no heating, or the heating system is broken beyond repair. And that's just their heating. And you're not even looking, as I said earlier, about the issues that are in behind. And that is one of the benefits coming out of Warm and Well, is that there now are avenues to direct those people to. And certainly, and it's only my opinion, people talk about a second wave. In my opinion, it never went away. And it hasn't gone away and won't go away, right? Until such times as there's a vaccine, or excuse me, a vaccine, and you can reduce it by nailing track and trace, so you can. But I think anybody that has been watching the news over the past couple of weeks will see that's not going to happen anytime soon. So it's not. And our transmission rates are climbing steadily. And so for us, we do very much anticipate that there will be an increase. And as I said earlier, we provided findings on 91, but actually at the stage that was submitted, we were sitting at 125, 126. And those levels have continued. And as we come into winter, without COVID, as I said, Lucy, you would know the phone rings hot. I would expect it to continue to ring even hotter once we get into a cold snap or a prolonged colder period. I could just said, yes, I expect an increase, couldn't I? That would have covered it.
Does anybody else have any questions? No? Would you like to sum up then, Hugh, or do you have got any final words?
All the best.
That'll do. How about
Maybe,
you,
yeah, maybe I could go refer a wee bit more to the meetings that we're planning with the different departments, because one of the things that really was most interesting to the Community Planning Partnership about this project really was how we could suppose, tap a number of assets and a number of partners who are even outside the community planning partnership, and how we could test some issues such as, could we have could we coordinate what we're doing? Could we address health issues from a wider determinants of health perspective, and so on? And one of the areas that's particularly pertinent, really, and which we talked to Pat Austin about and Hugh on Monday, was the need to really address the structural causes of the fuel poverty and the impact of cold weather and the cold. So on the health side, you could say, well, that's about flu vaccination and so on. And we saw that from what you said, that the most vulnerable in one are also the most vulnerable in the other. So it's all of a piece. But what we were talking about, and what we'll be talking to the departments and the housing executive and other partners about on next Monday, really is the importance of really taking a rational, systematic, data-driven approach to fuel poverty and to energy efficiency, rather than what has tended to be, I suppose, a silo approach, except for NEA, who have shown us the way often in these things. But rather than each department, say the Department for Economy, looking at the renewable energy target without really considering, well, what does that mean for those who are the most vulnerable or in the worst housing, or the housing executive looking at their own stock and not necessarily at other tenures, or the Department for Communities really asking for a more focused approach to this. So I think what the community planning partnership is looking at is this connection between the action on climate change and air quality, the action that we need to take now more than ever in terms of the construction industry and stimulating employment opportunities and setting up academies and so on for something that's going to have social value, and then taking an approach to health which is not just directly in the health bailiwick, but is actually something that needs the actions of all those other elements. So the Belfast City Council, for example, are keen through the resilience strategy board and the partners working on that to set retrofitting targets for Belfast. And I think we are looking to the energy strategy, perhaps to set energy efficiency targets alongside that, and really that becoming also a health target and addressing inequalities through the fuel poverty strategy. So aligning all those approaches together is really the great prize in this, where we're identifying and assessing and helping individuals is fine, but unless we have a structural, systematic approach across the city, and presumably it could be across Northern Ireland as well, if the departments pick these up, that needs to be at that level as well. So we've always got the two levels in mind: the citywide approach and the targeting of areas and individuals. So just to kind of make sure that people sort of heard that point. I don't know, Pat, if you wanted to come in on the back of that.
Yes, thank you, Ian. Yes, I think just as I suppose we have discussed earlier, the approach has been really good from yourselves and the City Council as well, and reflecting programme for government in that area-based approach has been very useful. I suppose really where the departments will now come in and play their role in supporting the project and this type of blueprint work, and how we can maybe replicate that across Northern Ireland is going to be very useful to us, because as I said, it's such a nice
project. It's doing lots of things, and it's trying to make those connections, which we have for many an age not been able to make. So we're definitely seeing inroads there, and it's definitely a really good blueprint for moving forward.
Okay then, so if there's any final questions? No? Well, what I can do is just let you know that this recording will be available on YouTube almost immediately, so you can have a look back at it again. And the presentations that were shown today will also be on our website. So just thank you to everybody for tuning in. And One Moment Week continues in the morning at 10 o'clock if you want to join us for even more sessions. So anyway, thank you very much, and we'll see you soon.
Thank you.
Thank you. Thanks.
All the best.
Bye now.
Bye.